o'clock, and we want to make sure that we give you ample time to ask your questions because we do have a hard stop at 1:30. So I just want to introduce everybody here today. Many of you know me. I'm Caroline Cornish with Maine Med and MaineHealth Communications. With us today is Katie Fulham Harris, who's our MaineHealth Chief Government Affairs Officer, as well as Nate Mick, who's the Vice Chair of Emergency Medicine at Maine Medical Center. He is also the president of our med staff. And we're going to have each of them give a couple of brief remarks on the crisis that we're seeing in behavioral health right now. And then we'll open up to questions. I'm going to call on everyone in the order in which you responded to our email. I would ask that everyone only ask one question to begin with, just because we're short on time. But once we get through everybody's questions, I'll give it another cycle if we do have time, if anyone has any follow-ups. So with that, I'm going to turn off my camera and send it over to Nick for some opening remarks.
Thanks, Carolyn. Again, Nate Mick from the emergency department. Really, for the past 2 years, our team in the emergency department has been under enormous stress dealing with the fallout from the COVID pandemic. Layered onto that, currently, we're dealing with a second pandemic, and that is of workplace violence against healthcare workers, often perpetrated by patients that really don't belong in our emergency department. And quite honestly, it's as bad as it's been in my 20 plus years in medicine. What we're seeing is patients with autism and intellectual developmental delay being brought to the ED from the community, and our healthcare team is being put in the worst possible position for a healthcare provider to be put in, and that is having a patient where they have very little therapeutic options to offer. We in the ED really do pride ourselves on being ready and able to provide care for acute medical and psychiatric emergencies, no matter the time or circumstance. But that is not what we're being called to do currently. The ED really is designed to react in those first minutes to hours of a medical crisis. It's not designed for care that stretches to days or weeks or months even, particularly for this patient population where we have little to offer. In these circumstances, the healthcare environment really does cease to be therapeutic. I guess the last thing I will say is if you have need to come to the ED for care, know that we are there for you, but please be kind, please be patient, and please be flexible with your healthcare team because they are under tremendous stress right now. And I'll turn it over to Katie for further comments.
Thanks so much, Dr. Mick. I'm Katie Fulham Harris, and I've been working on behavioral health policy for too many years now. Maine is currently facing a behavioral health crisis. When we downsized and closed our state institutions, we failed to invest in the continuum of services that is necessary to support patients successfully in the community. We are feeling that today more than ever. Our care team members are feeling that, the patients themselves are feeling that, and we're facing a very difficult situation. We appreciate and acknowledge the investments that this administration has made in supporting behavioral health, but much more needs to be done, and it needs to be done in a planful way, working collaboratively with providers, with consumers, and with family members to develop a strong system of services to meet the needs of Maine's communities. Thank you, and I'll be happy to answer questions.
All right, thank you both Nate and Katie, and reporters, if you can please make sure that you've renamed yourself with your name and your news organization. At first everyone had it that way, but I think some people added in later on that haven't done that yet. So if you can please do that just so we know who you are, so we can unmute you when it's your turn, that would be great. I'm going to start with Dan Lamparello from WGME CBS 13.
Thank you, Caroline. And thank you both for taking the time to discuss this important topic with all of us. And then this may be a question for Dr. Mick, but earlier this afternoon, some members of the Maine State Nurses Association held a press conference outside the hospital to talk about some of the violence that they've experienced, and also to talk about some of the demands that they hope to bring to hospital management regarding safety in the workplace. And my question is, do you believe enough has been done so far to protect the nurses within your ER? And do you plan on meeting some of the demands that they brought?
Thanks for the question. I'm really not part of the bargaining unit for the interactions between the union and management. You know, I think that we are doing all we can to support everybody in the ED who is providing care and to keep them safe. We're kind of between a rock and a hard place with this situation. And so I empathize. I'm there working clinically. We see this happening, and we're doing all that we can as caregivers to keep everybody safe. But the details around, you know, the interactions between the union and management is not something that's in my sphere.
Okay, next up is Chris Costa, New Center, Maine.
Hey, everybody, can you hear me okay? I was having some service issues earlier.
Yes, we can, Chris.
Okay, great. My question is I guess both for either Dr. Mick or for Ms. Fulham-Harris. Obviously the issue in some part has to do with patients who need more robust behavioral health care, as opposed to what Dr. Mick described, which is the emergency care that they're receiving. We know that there's a shortage of available behavioral health care beds in our state. Has MaineHealth have any ideas, plans, or possible solutions that it could present to open up more beds and move those patients that are currently in your emergency department to places where they could get the care that they need that would alleviate the violence on nurses?
Thank you. Great question, Chris. And let me say, yes, we do have suggestions. One of the suggestions I am happy to say is actually in the governor's budget, proposed supplemental budget, which is to create a secure residential treatment facility for children, because one of the big challenges we've had across the state is children who are getting stuck in our EDs because there are no appropriate residential options for them. We actually had, over the month of January, I think about the average child waited in the ED for over 5.5 days for waiting for behavioral health treatment. So that is a step in the right direction. We clearly need specialized residential treatment for patients with specific needs, patients with intellectual and developmental disabilities and autism, patients who are unhoused and have high levels of behavioral health need, patients who have substance use. We need detox beds for individuals who have substance use disorder. So we have a number of suggestions related to developing a continuum of care for these individuals. And we feel strongly that any types of investments need to be based in data so that we build the right amount of services to support the population of the state of Maine.
Talia Clark from WMTW News 8.
Hello, everyone. Are you hearing me okay?
Yes.
Okay, so my question is, so I was at the nurses rally as well this afternoon, and I did ask about security and why security isn't stepping up to help them in these situations where there is a violent attack. And they said there are shortages in that area as well. They claim that there's no nurse shortage, but a shortage of people willing to work in unsafe conditions, and that having more nurses on board would decrease these violent attacks. So I just want to know, what is your response to that statement, and what recruitment efforts has the hospital been working on to get more people on board?
So Talia, I think we can probably get back to you on that question, because again, that's a question about union negotiations, not about the topic about behavioral health care. So we can get back to you on that. Do you have a question about behavioral health or anything about the situation in the ED?
I don't mean to ask anything that's already been asked. I may have hopped on a little late, but how long has this been an issue? How long has the hospital been pushing for more of an effort on behavioral health? Has this been something that's been going on for a year? Has been going on, because the nurses we spoke to say that this has been happening within the last 6 months. They've seen an uptick of violent attacks. So I know that's associated with this somehow.
Yes. Thanks, Talia. I'd be happy to answer that. So as a system, MaineHealth has prioritized behavioral health policy at the state and federal level for the last 5 or 6 years. It has been quite some time that we've recognized that our behavioral health system was crumbling and that more needs to be done to invest in behavioral health and a continuum of services to better meet the needs of our patients and communities, and particularly in areas such as crisis services and residential placements for individuals with high levels of need. That being said, we also, as a result of the pandemic, have clearly seen an uptick in behavioral health needs across our state, across our nation. And I think that's creating even more pressure. It's exacerbating a problem that pre-existed the pandemic. So we are certainly spending a great deal of time with lawmakers and others talking about the importance of investing in behavioral health services, and particularly short-term solutions while longer-term plans are developed to better meet the needs of our communities.
Next up, Lana Cohen from the Portland Press Herald.
What exactly is the level of violence in the hospital? For example, how many nurses per year are hit with violence so that they have to take time off to recuperate?
Sorry, Lana, can you speak up? Your volume's a little bit low. We couldn't hear the question.
Yes, one moment. What can you hear me now?
Yes, that's much better. Thank you.
Okay, great. What exactly is the level of violence going on in the hospital? For example, how many staff are being hit with violence where they have to go home to recuperate or take time off to recuperate, and how many people are experiencing violence? What percentage of your nurses are experiencing this?
I can't answer the specifics. I don't have the specific data. What I can tell you is that one instance of violence is one instance too many. And we share the outrage of our patients, of our nurses, as well as our other care team members, that violence is occurring at all. And to that end, we feel strongly that our public needs to recognize the pressure that our hospitals have been under and their care team members have been under during the pandemic, and be kind and be thoughtful and be patient. And we need to do more as a state and a society in investing in behavioral health care as well.
And finally, Carol from Maine Public Radio.
Hi, good afternoon. Can you hear me?
Yes.
Thank you. I jumped on a little late as well, so I apologize if this is a repeat question, but the nurses were also asking about isolating specific patients that tend to be repetitive offenders with violent attacks. Is there any possibility of doing that? They just feel that certain individuals really do need to be isolated for their own well-being as well as the staff. Can anybody speak to that?
So,
I guess what I would say is, in an emergency environment, we do what we can do within the realms of an emergency department physical plant to try to keep everybody safe, both patients and care providers. But there are limits to what we are built to do within that ED around things like completely isolating one person in one room while still keeping them safe. So, I guess that's what I would say is we're working within the confines of an emergency department that really wasn't built to house folks for the long term that we're being asked to do so currently.
Are there other measures you can take with patients like that? And again, I'm not sure what is clinically available, but as far as possibly sedation or restraints, is that something that can be considered when necessary?
I'm not a psychiatrist in that sense, and I will say that clinically keeping somebody under sedation for days and weeks and months is not a therapeutic maneuver. It's not a great option for this patient population.
Of
And let me
course.
say, and to that point, I think we're here to really acknowledge the importance of investing in the services and the residential treatment options that are needed to support this patient population, who do not need to be in the hospital, certainly not unless it's a very specialized treatment facility, and they certainly don't need to be in our emergency departments. They are languishing in our emergency departments because of their disability. And they're essentially homeless individuals who, because of their disability, are living in our emergency departments. That is not okay, and we need to do better as a state to meet the needs of this population.
So this individual, I'm told, has been there for months, multiple months. Is that correct?
That is fair.
So
Thank you.
Carol, I had mentioned at the beginning, we were giving everybody one chance at one question, then we were going to be coming
I
around.
apologize. I'm sorry.
No, it's okay. You weren't there at the beginning. You didn't know. But I do want to, Chris Costa's asked for a follow-up. And if anybody else has a follow-up, we do have a little bit of time, but I'm going to call on Chris first. And then if anybody else, please raise your hand or send me a note in the chat. But Chris, you had a follow-up.
Thank you. And I think this question is for Dr. Mick, but Katie, if you have something that you can add for some insight, that would be great too. Please pardon my ignorance in how this works, because I'm not an expert in emergency departments, but it's sort of a two-part question. Part one, do nurses or staff know before they enter a room or begin to interact with a patient, this patient has the potential to be violent, has a history of violence, and then kind of on the back end of that, if a staff member experiences violence, what happens? Is there a reporting mechanism? Is there something they're required to do so that the hospital can keep track of these incidents?
So what I will say is it depends on the patient. Sometimes we do have information about prior past medical history or past psychiatric history, prior interactions with the healthcare environment that will give us some insight into the relative risk of a given patient and violence. But there are times where we don't. We have no information, or the patient doesn't have a history documented in their medical record that they have been violent in the past, and they can become violent. So it's one of the challenges of working in an emergency environment is that we kind of learn to expect the unexpected. But nobody in our realm expected to deal with workplace violence at this level. And it really isn't okay.
And Dr. Mick, do you mind just answering that second part? Is there a reporting mechanism for staff who experience violence?
Yes, I mean, it falls under, your typical, workplace injury reporting mechanism. For the staff member.
Okay, so but the hospital doesn't keep track of incidents of violence.
If it's reported, they do. Yes.
Okay, so then sorry, I had one quick thing based on what you said. You said sometimes you have information that a patient has had a history of violence or potential to be violent. Sometimes there's that information. When you have that information available, does the strategy or the approach change to interacting with that patient? Does a nurse go in with a security guard? How does that work?
I think it depends on the patient and depends on the caregiver and depends on, how that patient is presenting themselves. I think it's similar to any other part of their past medical history. We use all of the information that we have available at the time to make that initial assessment. And if there is concern, then care team will go in together. And we do have security there as a resource for those circumstances.
Thank you, and thanks everyone for the patience on the follow-up.
Thanks, Chris. Dan had his hand up as well. So Dan, go ahead with your follow-up question.
Thank you, Caroline. My question stems about the impact when you have people who are, for lack of a better word, living within the emergency room. What impact does that have on the services for people who need emergency services? Does that take away from the services that you can give to people who are coming in on a daily basis?
As the level 1 trauma center in the state of Maine, we were built for the volume that we anticipated. And every time we have a patient that stays, for days or weeks or months, that's a spot, that's a caregiver, a nurse, other providers who need to care for that patient. And so, yeah, it does. It impacts our throughput. We can never close our doors in the ED. Anybody that walks in for care, we're going to try to care for. We are limited in space if we cannot move patients to the most appropriate next step in their care, like some of these patients where there just isn't that resource on the back end.
Yeah, and let me add to that the Maine Medical Center ED has 6 specialized beds that it built for individuals with psychiatric needs. At the present time, I think 3 of those are filled with these longer stay patients. So that really compresses the availability of those beds for other individuals with psychiatric needs. And the whole need for a continuum of behavioral health services impacts not just the ED. The ED is really the place of last resort, but places like Spring Harbor Hospital, who have patients who get stuck because they can't be transitioned to the community because the community services aren't there. All of the pieces of the continuum impact one another. And we're here today because of a specific point related to the ED, which really is the safety net of last resort and is not appropriate for everyone. It is designed to triage, and it is designed to stabilize patients. It is not designed to treat and from a long-term perspective and keep patients for any length of time. So when we have behavioral health patients stuck in the EDs, it impacts not just the ED, but every step of the process along the way gets backed up. And that really creates challenges for patients with all levels of need.
All right, thanks, Dan. Oh, I'm sorry. Did you have one more follow-up or?
Oh, no, I just said thank you.
Okay, thanks, Dan. Lana had another follow-up as well.
Yes, thank you. You mentioned, Katie, that you were looking at short-term and long-term solutions. Can you elaborate on some of the short-term solutions you're looking at right now?
Certainly, there are specialized programs across the country that are available to patients who have specific levels of need. So that is one short-term solution. In addition to that, some of the providers, and I think the department today is releasing funding to support providers who have really struggled with the workforce shortage and the payment rates for individuals who are in lower levels of the treatment continuum, and therefore there's been a lot of turnover, and residential and group homes have been really a challenged place as a regards to those workers. So the support for those workers, as well as support for some of the community-based services such as ACT teams that help patients stay out of the hospital, are absolutely needed. MaineHealth operates some of those services, and we subsidize them substantially. So they don't all need financial investments, but there has to be a plan put in place that allows for the service continuum to be developed, be based on the needs of our communities, and as we know from the data that supports those.
All right. Thank you, everyone, very much. I don't see any additional questions. I appreciate everyone trying to keep this within the half-hour time. Reporters, if you have questions, I know you had a couple that we weren't able to cover here, please feel free to email them over. We'll try to get back to you as best we can. But thank you all very, very much for being here. Thank you, Katie. Thank you, Nate. And everybody have a great afternoon. Oh, wait, Lana says she's got one more question. All right, before we hang up, one more question from Lana.
Thank you so much. So as was reported in the Press Herald yesterday, Ricker from the National Nurses Union said that management refused common sense recommendations such as improving staffing for patients known to be violent with extra nurses and more security guards. Can you respond to that?
I didn't catch
Yeah,
that.
Lana, that as we said before, the union questions, Nate and Katie are not part of those union negotiations, but we can, and I believe we got back to Joe on that yesterday, but we can get back to you.
Okay, thank you.
Thank you. All right, thanks, everybody.